Assalamu alaikum and welcome to the recorded lecture on miscarriage or early pregnancy loss. This first of all I want to just clarify some terms that I always find a little bit confusing when kind of it's used here, how they are used here in Gaza. First of all, miscarriage means early pregnancy loss. And miscarriage, they belong together. So what you sometimes call abortion should really be called miscarriage or early pregnancy loss. On the other hand, I hear you guys talk a lot about termination of pregnancy when at the end of pregnancy, when we are talking about, for example, a patient who was 38 weeks. At that point, we talk about delivery, not termination of pregnancy. Termination of pregnancy is often associated with a termination of pregnancy in the first trimester, second trimester. So it's an elective termination of pregnancy because of either for some medical reason or social reason. And this is usually causing some confusion here. So I'm going to talk about miscarriage and not abortion in this lecture. This term has been changed really also for a better patient understanding and also removing stigma from this term. So in this lecture, we want to learn about different types of miscarriages, understand diagnosis and management options, and appreciate impact of common conditions on patients. We are going to do this with some case examples because I know you have already had a lecture, or you will have another lecture on early pregnancy loss. So this is not supposed to be a comprehensive lecture covering all the terms, all the possibilities of pregnancy loss, early pregnancy loss, but it is a lecture that is designed for you to apply what you have already learned to some cases that I'm going to present to you. So, first of all, why is it called early pregnancy loss? So, what is miscarriage, also called early pregnancy loss? So, because really, there can be lots of reasons why a pregnancy fails. This is not always an actually pregnancy that has been diagnosed and established and then kind of is miscarried. Sometimes the pregnancy loss is from the start, not there's a problem with this pregnancy. For example, there might be an unembryonic pregnancy or so. So therefore, you want to call it early pregnancy loss. Secondly, it is to do with the timing. So loss of a fetus before 20 weeks of gestation is called early pregnancy loss. After 20 weeks of gestation is called a late pregnancy loss. After 24 weeks, it is called a stillbirth. A pregnancy is called a stillbirth if it's born after 24 weeks. How common is early pregnancy loss? So here you have to know that it is very common. Some kind of calculations say it's up to 1 in 4 of all pregnancies. And 80% of these losses are in the first 3 months, and mostly this is before 8 weeks, actually. The vast majority of pregnancy losses occur before 8 weeks, but 80% of those losses are actually in the first 3 months. So what are possible causes of pregnancy loss? It is often unclear. 50% are thought to be of a genetic cause, that there's a problem with the karyotype of the fetus, for example, trisomy, Also, the age is very important, so pregnancy loss becomes much more common with increasing maternal age. So a cutoff is over 35, and again over 40 years, it's much more common. Other factors can be chronic illnesses that the mother has, such as diabetes or severe high blood pressure, kidney disease, connective tissue disease, and of course the flagship syndrome is here antiphospholipid syndrome. We also have an increasing number of other kind of coagulation disorders kind of associated with such problems. So here the number is growing, and our knowledge about this problem is growing, and we will find more and more connections here. Other causes can also be acute, so an acute infection, such as with rubella or cytomegalovirus. Severe emotional shock has been linked to miscarriages. Trauma, of course, especially abdominal trauma, blunt abdominal trauma, can cause a miscarriage. Multiple pregnancies are at higher risk of miscarrying. And polycystic ovary syndrome has also been linked to miscarriage, but this is controversial. Other problems, of course, can be that of uterine abnormalities, like a bicornuate uterus, fibroids, cervical insufficiency. All of these can be linked to miscarriages. So for that, what are the risk factors that women have to be kind of in a higher risk group with risk factors? And I want you now to write these down on your piece of paper, and then stop the video and start again when you think you've finished writing down all of your risk factors. Okay, so this, of course, maternal age is possibly the most common risk factor, the most important risk factor. Smoking more than 10 cigarettes a day is also a risk factor. Alcohol use, a fever. So a fever is linked, of course, to an infection. Infection can cause miscarriages. Trauma to the uterus, we already mentioned this, and this includes now also diagnostic procedures such as amniocentesis or chorionic villus sampling. And finally, increased risk of congenital abnormalities, such as certain medications people take, certain infections they have, radiation maybe, environmental chemicals. All of these can be risk factors for miscarriages. The other risks that I haven't repeated here are those causes from before, such as chronic diseases, and this is also an important factor in the risk factor profile for women to have risk factors for miscarriage. So here just an illustration of the link of miscarriage to maternal age. So you can see in women less than 30, there's only an 8% early pregnancy loss rate. 30 to 34, this increases slightly to 12%. 35 to 39, you see a more significant increase to 16 to 22%, but the main increase comes above 40 when more than 33% of pregnancies miscarry, and above 43, it's even 60% of miscarriages occur. So let us just repeat quickly the types of miscarriages that there are. There's the threatened miscarriage, inevitable miscarriage, incomplete miscarriage, and complete miscarriage. And I'm sorry, I do not have pictures now, but I want you to write down quickly what the difference, how you kind of define each of these different sort of miscarriages, and kind of continue with your slideshow when you have finished that. So A threatened miscarriage is vaginal bleeding with a closed cervical os. It's a common symptom, and half will have a normal pregnancy outcome. So only half will actually have a miscarriage and half will have a normal pregnancy outcome. An inevitable miscarriage is when you have vaginal bleeding with an open cervical os, and usually also abdominal pain. Not always, but usually also abdominal pain. An incomplete miscarriage is when vaginal bleeding occurs and expulsion of some of the pregnancy tissue through the os has also occurred, but not all. So you have some retained products of conception which are still inside the uterus. And then you have a complete miscarriage when you have vaginal bleeding has now stopped, the cervical os is closed, and all pregnancy products have been passed. These are the different forms of miscarriage. So when we look at the presentation, I just want to say I probably missed out one miscarriage here, which we come to talk about later as well, which is the missed miscarriage. This is a miscarriage where you have some bleeding. It kind of often you have some symptoms, or you might have no symptoms at all. So a miscarriage might have usually no symptoms at all. The patient comes for an early scan and then you find that there's no heartbeat. So there has been a fetal demise with the patient not kind of being aware of it or having any signs or symptoms of it. This is a missed miscarriage. So how do they present these patients? Just write the presenting signs down again. Vaginal bleeding, loss of symptoms of pregnancy is also a common presentation sign. So when they had breast tenderness, morning sickness, and suddenly this has gone. Abdominal pain and cramping is common and no symptoms. So the diagnosis is only at the scan, and this is the missed miscarriage I've just talked to you before. When there's no symptoms at all, but the diagnosis is only made on the scan. So, what do you need to kind of pick up in the history? You need to look at the presenting symptoms. So, what made them come to see you today? Are they bleeding? How much? Is it like a period or less? Have they got any pain, any tissue, any pregnancy symptoms, or have they had no symptoms at all? You want to, of course, find out the last menstrual period and the usual cycle, and so for calculation of gestation, and you want to know if they had used any contraception previously. And if this was a planned or an unplanned pregnancy is also important in that context. Other important aspects are if this is her first miscarriage or if she had previous ones before, and if she had her obstetric history is also important in that context. Had she had previous pregnancies and what were the outcomes of such pregnancies? So past medical history. You need to know the other other chronic illnesses, especially diabetes, epilepsy. What medication did she take? Did she take any medication? Drug history. Was folic acid taken as well? Allergies you have to find out always. The gynae history, are there any genital tract surgery? Has there been any genital tract surgery, or are there any genital tract anomalies, any fibroids? And you need to know about the obstetrics history, previous pregnancy, previous miscarriages, and at what gestation were previous miscarriages. So other past medical history, you have to also know any history of any thrombophilias, or has there been any testing done for thrombophilias. So you want to do an examination, and what is important in your examination here? You have to look at the general appearance of the patient and do her vital signs. So pain, discomfort, pallor, vital signs are important here, especially to see if they present with bleeding. You want to gauge how kind of severe is the bleeding. You need to palpate the abdomen. Is the fundus palpable? How is the abdomen soft, rigid, tender, non-tender? A speculum examination is important to assess the bleeding. So you want to know what is actually the amount of bleeding. Is there any tissue? And you can also take some swabs. Pelvic examination is also important. So I mean here by per vaginal digital examination, because you want to know if the cervical os is open or closed. This is not always clear from just looking at a cervix, especially in those that had babies before. You need to see, can I actually insert a finger in the cervical os? Is it open like that or is it not? Of course you have to be careful with this, because you do not want to poke your finger into a patient with a threatened miscarriage only. So you have to kind of course, be reasonable with that. And adnexal masses are also important to kind of see if there's any adnexal masses. So once you've done your examination, what investigations have you got to do for diagnosis? Absolutely, you have to do a transvaginal scan. This is the most important tool that you need for diagnosis. You might also have to do a full blood count to check the hemoglobin. Also, in some women, you need especially when it's their first pregnancy, you need to do a blood group if they do not know if they are rhesus positive or negative. If they come with severe bleeding, you need to, of course, do group and safe. But this is according to the clinical presentation. But you always need to do an ultrasound scan to be kind of sure, and it has to be an transvaginal ultrasound scan. This is to determine the location of the pregnancy. Is this intrauterine? Is it an ectopic pregnancy? And to determine if the pregnancy is viable. So finally, you also want to determine the gestation of the pregnancy. This is a picture of a uterus. You can see it. It's a transvaginal ultrasound scan, and you can see that this uterus is empty. Here's a picture of a uterus where you see a small gestational sac. This is quite small, and because it's kind of in this central location, it could also be a pseudosac. So this is there you have to be careful. But you have to know that an embryo is visible with 5 to 6 weeks usually. Fetal heartbeat is visible to 6 to 7 weeks. True gestational sac is visible at 4 weeks already. Okay, so this is a double echogenic ring in the cavity of at least 10 millimeters. So you can see how small we are talking about, how small kind of sizes we are talking about. And if a gestational sac is present, the mean sac diameter is 8 millimeters, and you can usually see a yolk sac. And if the mean sac diameter is 16 millimeters, you can see cardiac activity. So if you have a gestational sac with a mean sac diameter of 20 millimeters but no yolk sac, this is very suspicious, and it appears not to be a kind of a normal pregnancy. The mean sac diameter is kind of measured by measuring the gestational sac in 3 dimensions. So you do the width, the height, and then you turn the probe and you do another measurement so that you have a 3-dimensional measurement. You take all these, you add these 3 measurements and divide them by 3, and this is the mean sac diameter. So here you have a small gestational sac, and you can see the yolk sac within the sac. The good thing about seeing a yolk sac is always that you then know there's an intrauterine pregnancy. Even if you cannot see a fetus yet, like on this one, you can see maybe a fetal pole, but it's not a proper embryo yet that you can see here, only the embryonic pole. But the yolk sac confirms that you have an intrauterine pregnancy. So here you have a fetus, a proper visible fetus, and you can also do kind of a gestational assessment here with a crown rump length assessment. I have to warn you though, if this crown rump length assessment is such that the baby is less than kind of 6 to 7 weeks, it is actually not that reliable. So it should be more than 7 weeks to be a reliable assessment. You can see the long error on the yolk sac and the short error on the embryonic sac. And here you can see the crown rump length assessment that I have been talking about. This is very important to do for dating of the pregnancy, and this should be done. So all pregnancy should be dated properly with crown rump length assessment rather than dates. And for this you need a sagittal view of the fetus as you have here, or the embryo rather, as you have here, and you have to then measure it like that to calculate the date. And you can see the little yolk sac also attached to the baby, or near the baby. So the mean gestational sac diameter is measured before the crown rump length can be determined, so before 6 weeks. Okay, so you measure height, length, width of the gestational sac, you add them and divide them by 3. If it's 8 millimeter, you should see a yolk sac. If it's 16 millimeter, you should see cardiac activity. But if it's 20 millimeters and there's no embryo, no yolk sac, nothing, then you have to ask yourself if you have an unembryonic pregnancy or blighted ovum in front of you. Another difficulty in the early ultrasound scan is to sometimes distinguish the pseudo gestational sac from the true gestational sac, and this can be done if you see no double ring in the cavity. Then it is more likely to be a fluid collection in the endometrial cavity rather than a gestational sac. So this could be found if the patient is not pregnant, if you have an early gestation, less than 4 weeks, or if there's an ectopic pregnancy. And here, of course, quantitative HCG is very important. So to see a gestational sac, you should have an HCG of 1,500 to 2,000, and then a gestational sac is definitely visible. Poor prognosis the following findings have a poor prognosis for the patient, for the baby. This is a slow fetal heart rate, an irregular shape of the gestational sac, a very small gestational sac, subchorionic hematoma, presence of embryonic anomalies or abnormalities of the intervillous blood flow. All of these might have a poor prognosis. So here you can see some mean gestational sac measurements. You can see on the left side, this is the same patient, the same gestational sac that is being measured. On the left side, you see a sac being measured in the width and also the length, and then the probe has been turned 90 kind of turned up or turned down, so by 90 degrees, and then you can see there's another measurement done. All of these are kind of counted together. This is done by the computer and gives you a mean gestational sac diameter. In this picture, you could see a subchorionic hemorrhage. It's actually quite a large subchorionic hemorrhage. They might have a poor prognosis, but not all of them. It doesn't necessarily mean that this pregnancy will fail. But it might mean that the patient has got some ongoing slight bleeding until the subchorionic hemorrhage has resolved. Here you see a chronic subchorionic hemorrhage. This is not so acute. And then you have a resolving subchorionic hemorrhage when you have only a little bit of hemorrhage seen, and actually it has kind of gone resolved, and it does not cause any further problems. And you can see the pregnancy is still there. So let us look at several cases and discuss the management of miscarriage. First of all, we go over the options. We have conservative management, we have medical management, and we have surgical management options. And please just write down on your piece of paper now what they are, what is meant by conservative, medical, and surgical. And then we can discuss them in more detail later on. So in conservative management, you can offer to the patient if the patient is stable and a definite diagnosis was made. So it does not mean that you still wait. We're talking about management now of patients who have a definite diagnosis of miscarriage. We are not talking about those patients that we are not too sure yet, and we ask them to come back to kind of confirm that it is a miscarriage. No, we're talking about those where we are certain this is a miscarriage and a non-viable pregnancy. So conservative management is always a good option at first, and this can be depending on the patient. Usually it's kind of set 14 days wait, 14 days. It can be between 7 and 14 days wait, and 60 to 80% will abort spontaneously. This is of course preferable to any intervention. Medical management actually includes means oral or vaginal misoprostol. It should have, so a miscarriage should have 8 micrograms of oral or vaginal misoprostol at once. Incomplete miscarriage should have 600. This is followed by further doses as per protocol, usually every 3 hours until the complete pregnancy has kind of been expelled. Here I have to say that one of our students 4 or 5 years ago now has done an audit into the management of early pregnancy loss and has found that many of the medical management cases failed and had to have surgery afterwards. But at the same time, it was clear that they had given those patients not 800 or 600 micrograms of misoprostol, but they had only 200 initially. And the NICE guideline actually say that with these higher doses, there's a larger kind of chance for success. Also, maybe they didn't wait long enough to kind of give them repeat doses and really give them a chance to expel the fetus without surgery. So it's important to have a clear protocol and follow the protocol in these situations to avoid a high failure rate for medical management and therefore also a need for surgical management. Surgical management can be done in 2 ways. First of all, it can be done by manual evacuation, so under local anesthetic in the clinic setting, and kind of evacuation of this with the curette, of the products with the curette, or it can be done by vacuum evacuation of retained products of conception under general anesthetic. Which method the patient chooses is important. So the decision on which method is kind of taken is important to include the patient into this decision and kind of explain to her all of these 3 ways, choices, and kind of see what the patient herself prefers. Aftercare and advice afterwards is important. So these patients should use no tampons for 2 weeks. They should have no sexual intercourse for 2 weeks. Of course, you have to consider vitamin D for rhesus negative women, and they might need emotional help and support. For you as a doctor, attending doctor, this is just a routine, a common problem which you can kind of deal with easily and doesn't tax you too much. But for the patient, this might be a devastating life event. And therefore, it is very important to recognize this impact it has on the patient, and to give her support, show empathy, and give her space to deal with this disappointment. So there's a few points that patients need to have explained to them. First of all, that miscarriage is common. So miscarriages are not always talked about very much. So patients might feel, I'm the only one who has a miscarriage. Everybody has just successful pregnancies. But this is not true. It is because maybe women do not want to remember and do not talk about miscarriages as much. There's a same chance of a successful pregnancy after one miscarriage as if there had never been a miscarriage before. Often this is connected to especially one-off miscarriages, so not recurring ones, but one-off miscarriages are often connected to genetic problems within the fetus. So it is a way of nature kind of sorting itself out, and this is important to explain. Very, very important is, and this question comes a lot. Patients might ask you, is it because I have cleaned the house or washed the windows or done things like that, or carried hard? And this is not true. So nothing that the patient has or has not done has led to this miscarriages. It's just one of those things. It's the genetics of the baby or some other factors, but it is not usually a fault of the patient at all. And this is an important information to give to patients because they might have feelings of guilt and regret, and this is important that they know it's not they are not to blame for this. Finally, 20% of women suffer from some degree of depression following a miscarriages, especially if these are recurrent miscarriages, and this has to be taken into consideration when you consider the support that a patient might need. So let us go through a few cases now to just illustrate how miscarriages can present and how the diagnosis actually miscarriages due to different causes can present very similarly. So let us look at this 26-year-old patient who presents with bleeding less than a period and no pain, and her LMP was 7 weeks ago. So what do you do next? Absolutely, you have to do a transvaginal ultrasound scan, and this scan shows a fetal pole with cardiac activity visible. So what is the diagnosis? Absolutely, the diagnosis is a threatened miscarriage. And what is the management? Management is observation. If bleeding is not settled after 7 to 14 days, or if it's getting worse, the patient should be advised to return for re-evaluation. So you cannot tell the patient everything is normal, mir min mir, as you like to say, doctors like to do here. You cannot do that because there is bleeding, so it's not all fine. But at the moment you can say the pregnancy is fine, and 50% of pregnancies, even with a bit of bleeding, will kind of continue and be successful. And therefore you can be optimistic, but you cannot say everything is normal. So, and you have to explain to her, you have to safety net this patient when you send her home. You have to safety net and say, come back if there's still bleeding after 7 to 14 days, or if the bleeding is getting worse, come back immediately. So if we look at this again, and we look at the transvaginal ultrasound scan where you see an intrauterine sac of 10 millimeters, but you see no cardiac activity. So you have the same presentation, a 26-year-old patient who presents with bleeding less than a period and no pain, but this time and also LMP of 7 weeks, but this time you see a gestation sac of 10 millimeters, but you see no cardiac activity. So what What is your diagnosis? So your diagnosis will be an intrauterine pregnancy of uncertain viability. It's only a 10 millimeter gestation sac, and it is possible that this pregnancy is still kind of early and will kind of you just cannot see the cardiac activity yet. But it is also possible that it has not, and that the dates maybe are not correct, so that her cycle maybe was longer and her date is inexact. But this is not clear at this moment. So your management is observation and kind of repeating the ultrasound scan after 10 to 14 days. So it's important not to bring patients back too early and too much. On one side, it is good to give them an appointment to say in a specific day, come back on this day, so they know when to come back. But if they come back too early, they might get too anxious and upset about diagnosis that they didn't kind of want to have, so findings they didn't want to hear. Okay, so it's important to give them a day to come back to safety net and say if you have any pains, any bleeding, anything, come back earlier. But if all is fine and you feel fine, come back in 10 days or 14 days. So let's look at another case then. A 24-year-old with heavy vaginal bleeding, more than a period, and some lower abdominal cramping. So what can be your diagnosis, and what have you got to do next for kind of making the diagnosis? You have to, this patient, if she seems to have heavy bleeding, so you need to assess how much bleeding there is. So this might have to be done with, you might need to do a speculum examination first, where you can, examination of the abdomen, speculum examination, looking at the heaviness of the bleeding, assessing the heaviness, looking at the cervix, seeing if there's any tissue there already or not. But what is important is, of course, the ultrasound scan, and you might remember this picture. This is a patient who has an acute subchorionic hemorrhage. So you find a 20 millimeter gestation sac with a fetal pole, but no heartbeat, and a subchorionic hematoma. What is the diagnosis, and what is your management? Write it down on your papers. So the diagnosis is fetal demise or missed miscarriage. Not quite missed miscarriage, actually. It is fetal demise because she presented with symptoms. But what is your management? Your management can be either depending on how heavy the bleeding is. So if this patient has heavy bleeding, it was said to be more than a period. So in heavy bleeding, you can admit her and observe her and see, give some misoprostol to see if this helps her pass her all of the tissues. If she has a lot of bleeding and her hemoglobin is low, or she's kind of her vital signs she's not stable, then of course she needs to have an immediate surgical evacuation to stop the bleeding. So this is another again the same history, but you see here another kind of ultrasound scan. And what do you see here? It's an empty uterus. So, so sorry, I put this picture. So this is supposed to be a pseudo sac, so not a proper sac, where you have an empty uterus and no gestation sac and no yolk sac. In these patients, you are kind of extremely worried, of course, because you worry about, this is what you then say, you have a pregnancy of unknown location. So there's a pregnancy there, the HCG is positive, but where is this pregnancy? This could be an ectopic pregnancy, it can be an embryonic pregnancy, or a complete miscarriage. And the way you can the history is very important when you want to distinguish or um, um, find if you want to distinguish an ectopic pregnancy from a complete miscarriage. So if a patient comes to you and has 7 weeks and just with a bit of bleeding, and then you find an empty uterus, you will be you will of course ask her, have you had any bleeding? If the patient tells you, I've had a lot of bleeding and now it has stopped, then it is more likely that it might be a complete miscarriage. This is more likely. It's not a definite thing, but it's more likely. If she tells you, no, I just had a little bit of bleeding, but maybe she then tells you, but I started having this pain on my left side, then you are more worried it might be a pregnancy, an ectopic pregnancy. If she tells you, I had a lot of bleeding and crampy pain all across my lower abdomen, then it sounds more like a complete miscarriage. Unembryonic pregnancies are not that common actually, but they are an ultrasound diagnosis. So you need to assess the patient, assess the strength of her bleeding, any adnexal masses, any pains. But it's very, very important to do her HCG measurements. If you're not sure, if you're dealing with a pregnancy of unclear or uncertain location, then you have to do her HCG quantitative measurements and follow these measurements. See if you find a doubling if you find a doubling of the result within 48 hours, and keep her in for observation. This is of course only possible if she's stable. So this patient has to be stable for this sort of observation. Now you have a 35-year-old patient with last menstrual period 10 weeks ago. She has a regular cycle and she comes to see you as she's worried. She had no bleeding, but she has found that her morning sickness and breast tenderness is not the same as in her previous pregnancies. So she's had 4 children before, and it's not her first pregnancy, and she found that she this time has not the same amount of breast tenderness or sickness. So she just wanted to make sure that everything's fine with this pregnancy. And this is the finding you have. And here you can see a transvaginal ultrasound scan, which shows you a reasonably sized gestation sac. You have to, of course, see the exact measurements to be sure. And you see the double ring around the gestation sac here. So it's more likely actually to be a gestation sac rather than an empty collection of fluid or blood. But you cannot see a fetal pole. So the measurements are that you find a double ring visible with no yolk sac, and the mean diameter of the gestation sac is 20 millimeter of size. So what is your diagnosis? It's an unembryonic pregnancy. And the management, what is your management? Your management is usually at this point either conservative, medical, or surgical. She's free there. Sometimes conservative management, you can always try conservative management. There's nothing against that, especially if the patient really wants conservative management. This is good. But you have to remember that she might have already had this sac for a while, and nothing has happened so far, so it might not be successful in her as it might be in other in women who already have some bleeding. So the summary, let us summarize from this presentation. Bleeding in early pregnancy is a common presentation to emergency departments in gynecology. It causes a lot of worry and anxiety to women. History and examination are important, but investigations are also very important. So transvaginal ultrasound scan, full blood count, and also blood group, if the blood group is not known, have to be done. Similar presentations can be evidence for different diagnoses. So from the presentation alone, you cannot always make, you need the full clinical picture to make a diagnosis. It is very important to recognize that miscarriages have a major impact on women, and women feel quite upset about upset is a difficult is not a strong enough word, but miscarriages can have an emotional impact on women that has to be recognized and appreciated. So women have to be given information, they have to be met with empathy, and they have to be included in the choice for which management option they choose, has to be included in the choice of management in the end. Thank you very much.